So welcome everybody, and thank you for joining this EAACI-FAAM Nutricia Satellite Symposium on the topic of symbiotics in cow's milk allergy management, the inspiration, effect of cow's milk allergy outgrowth, and impact to immunity against infectious diseases. I'm Nikos Papadopoulos, Professor of Allergy and Pediatric Allergy at the Universities of Athens and Manchester, and we have a great panel today. It's Professor Jan Knoll, a Senior Science Director of the Gut Biology and Microbiology Platform at Danone, also Professor of Microbiology at the Wageningen University in the Netherlands. Professor Kirsten Beyer, Professor at the University of Charité in Berlin. And Professor Anja Novak, a Professor of Pediatrics in the New York University School. And they will talk to us, Jan, about symbiotics and inspiration from human milk and effect on the gut microbiota. Kirsten is going to present about the effect on symbiotics on the outgrowth in infants with IgE-mediated cow's milk allergy. And finally, Anja will show us about how symbiotics modulate the gut microbiota and strengthen immune defense in cow's milk allergic infants and implications for clinical practice. After the presentations, we're going to have a panel discussion. And we can now start with the first presentation from Professor Jan Knoll. Jan.
Hello everyone, good day. It's a pleasure for me to speak on this special online event. And I'm happy to present some work we've done on the concept of symbiotics in early life. And I would really like to talk about the inspiration we got from human milk and how these symbiotics can affect the gut microbiome in infants that particularly need support on the microbiome development. Just to start with, my disclosure, to be clear, transparent, I'm a full-time employee of Danone Nutricia Research in the Netherlands. And besides that, I'm also part-time professor in microbiology, gut microbiology at Wageningen University in the Netherlands. So early life is really a critical time for development of the infant, as you all know. The infant is not mature, many of the organ systems are not mature, and steps still have to be taken after delivery into this world to grow the body, to grow the whole biology of the system. And we know that specifically also the gut has to mature. The microbiome has to establish because infants are born more or less sterile without microbes, and they have to colonize the guts and form the gut microbiome. But also the immune system is rather naive when we are born. So the immune system also still has to learn what are good signals from the environment, what are danger signals. And these processes go pretty much hand in hand. So the development of the immune system in early life is triggered, of course, by the food we eat, the milk the babies drink, and this then triggers, of course, the maturation of the whole gut system. The microbes entering the system, the maturation of the immune system should then lead to a stable homeostasis that supports our health throughout life. But of course, also things can go wrong in early life, and this is what we see more and more, and we see the rise in infections and allergies in early life, food allergies, but also asthma. And also immune disorders or non-communicable diseases in later life. So it's really important to understand this early phase in life and how we can support the optimal development of the system. And it's quite clear for all of us, I think, that a healthy gut microbiota is important for the development of the immune system because they react so much to each other. A large part of our immune system is in the gut. And in the gut is also where all these microbes in high numbers are becoming very active. So to regulate the microbiome composition, the immune system plays a role. But of course, microbial signatures also have a huge impact on immune responses on the host side. So the early exposure is important to both develop the gut microbiome as well as the immune system. And there's lots of interactions going on in this very interesting organ. Of course, the gut is responsible for digesting our food, taking up essential nutrients and energy, but it's a rather complex system where the mucosal immune system really plays a very important role in maintaining immune homeostasis, suppressing responses to harmless antigens, including beneficial bacteria, but also responding to threats like toxins or pathogenic bacteria. And we know that if the process is not going very well, we get a disbalance, also referred to as a dysbiosis in the microbiome, and this can trigger several immune disorders through also activity of T cells. And the most important ones are, of course, allergic reactions, but also, on the other hand, infections. And we know now very well that the microbiome, once it's developing and established, that this gut microbiome actually is a very important barrier against pathogens. So a healthy and balanced gut microbiome acts against infiltration of less desired microbes, pathogens, and therefore preventing also infections that these pathogens can cause at the epithelial layer. And there's many mechanisms behind this. Of course, it's a very crowded space where microbes compete heavily. And of course, the good bacteria can in this way compete with the pathogens for adhesion sites and nutrients, for example, which leads to production of acids, weak acids, that again are also very much inhibitory to all kinds of pathogens. So an acidic environment is created where specifically saccharolytic bacteria thrive. The well-known bifidobacteria, lactobacilli, they love these conditions, but pathogens cannot colonize these systems. Of course, the bacteria also support the epithelial health, including tight junctions, but also mucus production. So by supporting this barrier integrity on the host side, beneficial bacteria can also make us resistant against the more pathogenic bacteria. But in modern life, there's also quite a few threats to the developing microbiome. There's quite a few things that we put on the developing system these days that can cause disturbances or dysbiosis. Practices have changed, sometimes also, of course, for very good reasons, like the use of antibiotics. It has saved many lives and solved many infections. But you can imagine that early life antibiotics have a huge impact on the developing microbiome. Duration of gestation is important. So preterm infants, they have also an aberrant microbiome development, and preterms is also on the rise. Of course, C-section, very important example, I think, because infants that are born in a sterile operating theater have a very different exposure to the microbial world after they are born than, of course, naturally delivered infants. And we see that this has also a big impact on the developing microbiome. Hygiene has changed, diets has changed. So in the last, let's say, 100 years or a bit more, of course, this is big impacts on the developing microbiome. But if the microbiome develops well, we go into a healthy system, a homeostatic system, which is important for immune tolerance, for gastrointestinal homeostasis, but also for healthy metabolism. And nowadays we also realize the important link of the gut to the brain, that this can even impact also brain health. But if the microbiome is disturbed significantly in early life, we can also have dysbiosis, which is quite often associated with immune diseases like allergy, asthma, gastrointestinal diseases, but also metabolic diseases. So it's really important to understand how this development is influenced by factors like diet. And this is, of course, an advantage that with nutrition we can directly target the lumen of the gut and influence also the microbiology of the gut. And this is also what we see in cow's milk allergic infants. They often have an altered gut microbiome compared to healthy, non-allergic breastfed infants. So healthy infants have dominant levels of bifidobacteria. We also see E. coli, Faecalibacterium prausnitzii as a butyrate producer is important to also establish in early life. And we see many different lactobacillus species to be there from an early stage in healthy breastfed infants. But in allergic infants, we quite often see that these numbers are lower and that we see more prevalence of Enterococci, Methanobrevi, Clostridia type of bacteria. So we seem to have this dysbiotic state in cow's milk allergic infants specifically. And of course, we have solutions also as nutritional solutions for allergic infants. Many formulas, of course, are there to support these infants high risk of allergy or already suffering severe allergies. But of course, these formulas do not always contain the right support for the microbiome. Whereas human milk contains even live bacteria, we now know. Human milk also contains a lot of substrates for beneficial bacteria. So human milk is actually really driving also the development of the microbiome. Human milk is not just feeding the infant calories and building blocks, but human milk is also actually feeding the microbiome. And in traditional formulas, of course, this was lacking. These formulas usually did not contain live bacteria or prebiotics, human milk oligosaccharides to support the growth of beneficial bacteria. So this is where this concept comes into play, the symbiotic concept. We think best of both worlds. Just for the people that don't know, symbiotics is a combination of prebiotics, so the substrates for beneficial bacteria to let them grow and be active in the gut, plus probiotics, which is actually feeding individuals or babies with live bacteria. And if you give them at high numbers, we can impact the gut microbiome, and we can actually also confer health benefits to the host, to the infants with these concepts. Well, we have a lot of data, of course, behind this mixture. As many of you may know, we have a lot of data on the prebiotics, the GOS and FOS and FOS and FOS mixtures, which actually mimic the level of substrate in human milk, but also functionality. They're of course not the same molecules, but they very much have the same functionality. And we have studied this in more than 30 clinical studies. And there's also now recommendations for these prebiotics, or at least acknowledgements for the benefits of these prebiotics. Then we have also in this concept a probiotic for which we have selected a very specific Bifidobacterium breve, the so-called M16V strain, because Bifidobacteria are in human milk, they're in the gut of healthy breastfed infants, and this specific strain is selected because it's able to reduce allergic responses, at least as shown in preclinical, but now also in clinical studies. So this is very strain specific for this specific probiotic. And together, by influencing the microbiome, the activity of the microbiome, but also providing specific live bacteria, we can synergistically target the gut microbiome in dysbiosis. So we have a lot of evidence, data, of course, from human milk. We still learn every day from the composition of human milk, a very intriguing liquid. And in human milk, of course, we have very large amounts of very different human milk oligosaccharides. And these have different functions, but an important one is also, of course, to act as a substrate for the growth of bacteria in the GI tract of babies. And now we have mimicked more or less this complexity of molecules in size with very different sizes, with also the development of specific prebiotic mixtures, where we have the same size distribution, a lot of diversity in molecules, and also these substrates, specifically the galacto and fructo oligosaccharides, are good substrates for beneficial bacteria in the GI tract. A few more words on the probiotic, the M16V. I truly believe it's a unique infant strain. Bifido breve is really the most commonly isolated species from human breast milk. It's in the gut of healthy breastfed infants. It's a typical infant human type of Bifidobacterium, in contrary to some of the other species like Animalis or Lactis. The strain is therefore also resistant to certain antimicrobial activities in human milk, showing indeed that this strain is also present when infants are human milk fed. Very adapted to this niche, and I think it's really an example of co-evolution between us humans and bacteria, where this collaboration is also supported by, for example, human milk. We have a lot of safety data also on this probiotic strain, specifically in sensitive populations like infants. It was also very much selected because of this strained data we have on safety. For example, this strain has no undesired antibiotic resistances, which is quite a big topic in using live bacteria these days. And we also have a lot of in vitro and also animal models, data from that to ensure that Brava is colonizing, is efficient, but it's also free from any major allergens in the production of this probiotic, which is also quite unique. Well, we have studied this concept of symbiotics already for many, many years, and we also have a lot of clinical data to support the safety, the efficiency, the equivalent, or the suitability, let's say, of this concept in this target group. So we have scientific data from our preclinical work. We have mechanistic data also on immune models published already more than 10 years ago. In the study of Harvey, we've also shown that this concept is safe in healthy infants and that it's hypoallergenic according to the AAP guidelines. And then in further studies published by Burks and Candy, we also have seen that this concept is safe, well tolerated in infants with cow's milk allergy. And we are still running a big study, the PRESTO study, where we look on microbiome effects, but also on immune development effects in these cow milk allergic infants. So the data is in different target groups. We have safety data in healthy and in high risk and in allergic infants with extensively hydrolyzed formulas, but also amino acid formulas. And here's just a global overview of the studies and the objectives of these studies. And most of this has been published, so you can still look them up in PubMed. And also further speakers in this session will present a bit more data on the latest studies that we've done with this symbiotic concept. Just to highlight, now we have 3 big studies, randomized studies, to really demonstrate that symbiotics are actually able to target this dysbiosis that we see in some diseased infants, specifically also the allergic and cow's milk allergic infants. So intervention with symbiotics does increase, for example, the beneficial bifidobacteria. We see decreases of bacteria that are more common in adults. So the eubacteria and clostridial groups, they decrease if you use symbiotics. We also change the gut environment. So we see lower pH, shift in short chain fatty acids, bringing the gut microbial physiology, I would say, much closer to healthy breastfed infants with using symbiotics in the diet of these infants. So in cow's milk allergic infants, in amino acid formulas even, we see this increased levels of bifidobacteria and reduced level of adult type of bacteria. And of course, this is important. These infants are diseased. They also have a specific challenge on the microbiome. So even if you give these infants a very special diet of amino acids, by adding symbiotics, we can really support composition, but also activity of the microbiome. And this is also the case in the non-IgA mediated allergies and in the IgE mediated allergies. So to conclude, I think we all are aware of the importance of the developing gut microbiome for the developing immune system, and that it's really important in early life to prevent also infections, so to get the wrong bacteria into the system. And human milk, of course, is a great aid there because it contains antimicrobials, antibodies, but also substrates for beneficial bacteria to guide this process of developing the right microbiome that is then able to also steer and develop the immune system in the right way. Symbiotics, combination of prebiotics and probiotics, also mimicking components in human milk, can target this gut microbiome dysbiosis that we see in many diseased infants. And we also now have 3 clinical studies showing that this specific symbiotic mixture is actually able to rebalance the gut microbiome in infants with cow's milk allergy and bringing it closer in composition, but also in activity, which might even be more important, to that of healthy breastfed infants. So this is where I would like to conclude Thank you very much for your attention, your online attention, and we're happy to also have a panel discussion later on to answer any questions you may still have. So thank you very much again for your attention.
So thank you very much, Jan, for a very interesting presentation on this incredible world of the microbiota. And now we move to the presentation of Kirsten Beyer. Kirsten.
Yes, thank you for inviting me to give this presentation. My name is Kirsten Beyer. I'm head of the research clinic for pediatric allergy at the Charité University Hospital in Berlin, Germany. And I will talk to you today about the effect of symbiotics on tolerance development in infants with IgE-mediated cow's milk allergy. Before I give you my presentation, you will find here my disclosure. And this is a company-sponsored symposium, and I will receive a honoraria for this presentation. As you all know, cow's milk is one of the most common food allergens in early life. And the prevalence rate of cow's milk allergy range from 0.5 to 3% at 12 months of age. Cow's milk can cause many different symptoms. The most common ones are immediate type reactions, which are normally IgE mediated, but cow's milk can also cause worsening in children with atopic eczema of the skin conditions, but also it's a common cause of gastrointestinal diseases that are normally non-IgE mediated. As you can see here from the data from the European Anaphylaxis Registry, where 1,970 children were included, you can see that cow's milk is a common trigger of food-induced anaphylaxis. You see the cow's milk here in dark blue, and especially in the first 3 years of life, it's very common that cow's milk is a cause of these anaphylactic reactions in children. Luckily, this goes over time because of cow's milk allergy has a very good prognosis. But how long does it take to outgrow cow's milk allergy? What you see here on this slide are data from various studies, and I would like to point out the one in green. These are data from the Europaval birth cohort, where we had over 12,000 children from 9 European countries followed up over 3 years. And you can see here the children with cow's milk allergy, that about 70% of these children outgrew cow's milk allergy within 1 year. And this data nicely confirmed previous data from over 30 years ago from another cohort study, what's shown here in light blue, and this data almost reflect one of the other. But there are also other studies, and this shows a very heterogeneous picture where cow's milk seems to outgrow not as fast. But these are data from clinical trials. They were either retrospectively recorded or the children were not followed up with fixed intervals with oral food challenges. So these heterogeneous pictures come from really different methodologies. Looking more closely at tolerance development, you can also distinguish children with IgE-mediated cow's milk allergy, shown on the right-hand side, or from non-IgE-mediated cow's milk allergy, shown on the left-hand side. And please focus first on the blue, green and yellow lines. These are in both, these studies had both children with IgE and non-IgE-mediated cow's milk allergy using the same methodology. And what you can see here clearly, that children with non-IgE-mediated cow's milk allergy outgrow much faster their disease than children with IgE-mediated cow's milk allergy. And again, there are also some studies indicating that even in the children with IgE-mediated cow's milk allergy, the outgrow is even slower than in these cohort studies. With this, I would like to come to the PRESTO trial, what was a trial to look at the effect of an amino acid formula with or without symbiotics on the natural history of cow's milk allergy. So the objective of this trial was to evaluate the development of cow's milk tolerance, of allergy symptoms and safety of these formulas. This was a 12-month intervention, and the primary outcome was a proportion of subjects who developed tolerance to cow's milk after 12 months of intervention measured by a double-blind placebo-controlled food challenge. We included in the study 169 infants with a confirmed IgE-mediated cow's-milk allergy at a mean age of 9.4 months. And the product, as I said, they received either an amino acid formula without or with symbiotics, and you heard already in the previous talk something about this. After screening for eligibility, the children were randomized and started with the study product. The children were up to 13 months of age with an IgE-mediated cow's milk allergy, and we included into the study also children with anaphylactic reactions in the past and also children with multiple food allergies. The study was conducted at 18 study sites in 6 countries. After randomization, the children received for 12 months a test of the control formula, so the Neocate Senior or the Neocate LCP, and then they were followed up for another 12 months, so month 24, and I will present you the data from these 2 time periods. Looking here at the consort diagram, you can see that the dropout rate in this cohort was very low. At 12 months, only 7% of the children dropped out, and at 24 months it was below 14%, what is a very good rate. The demographic between the children who received the test and the control formula was very similar. The mean age, 9 months, and it was majority males with 71 to 73%, what is very well known in cow's milk allergy that it's male dominant. Also, there were no major differences between race or country of resident. Here you will see the data of the 169 children altogether after 12 months intervention and at month 24. And as you can see here that after 12 months, about half of the children outgrew their cow's milk allergy, and at month 24, almost 70% had outgrown their disease. Looking at the children who received either the amino acid formula with or without symbiotics, and in purple you see the children receiving the amino acid formula with symbiotics, and in blue the one without. You can see here that after 12 months and also after 24 months there was no difference in these populations. So whether they received it or not, the outgrown was very good in these populations. Comparing this to other studies, you can see this on this picture here. On the right-hand side, the dark purple shows the children from the Presto trial, the one who received the amino acid formula with or without symbiotics. And you can compare this with the various studies I had shown you before. The Turkish one here from the Europroval study, the study from Hose and from Sarinen, and it's very comparable with these results. Comparing this with another study from an Italian cohort where an extensively hydrolyzed formula with or without LGD was used, it even gives you the impression that the tolerance development in the children from the Presto trial was even faster. So although the studies are very heterogeneous, age at inclusion is a little different, the follow-up periods, the formula which I use it, what we can see is that natural tolerance development in these children after 12 to 18 months from the Presto trial is quite comparable with previous studies. Looking at the safety of the products, both formulas were similar safe, but what was very interesting to see when we look at serious adverse events in regard to infection, and the seriousness of these adverse events was mostly from hospitalization due to infection. What was seen here is that the test product, so the amino acid formula with symbiotics, led to a significant lower rate of serious adverse events due to infection from 9% versus 20% in the control formula. So the key message from the Presto trial is that about half of the children in this trial with IgE-mediated cow's milk allergy developed oral tolerance to cow's milk within 12 months, an additional 13% within 24 months. The tolerance development is in line with what is reported in the literature. Children receiving the amino acid formula with symbiotics required fewer hospitalization due to infection, and Anja Nowak-Wengren will talk more about this in the next presentation. With this, I would like to thank all my colleagues who were involved in these trials, all physicians and research nurses, and especially all participating families, and thank you very much for your attention.
Thank you very much, Kirsten, for presenting to us all this data about the PRESTIGE study. And now we move to the presentation of Anja Nowak. Anja.
Welcome. My name is Anna Nowak-Wengren. I am a professor of pediatrics at the NYU Grossman School of Medicine in New York, and it is my great pleasure to discuss clinical benefits of symbiotics beyond the dietary management of infants with cow's milk allergy. Here are my disclosures. I do receive honorarium for this presentation from Nutricia, and I received a research grant, and I was a site PI for the multi-center international clinical study PRESTO trial of an amino acid-based formula with symbiotics. My objectives for today are to discuss the prevalence and relevance of infections in early life and among allergic infants with cow's milk allergy, and to describe the effects of a hypoallergenic amino acid-based formula with symbiotics on infections in infants and young children with cow's milk protein allergy. As pediatricians, we all appreciate that simple infections can have a considerable impact, and we also know that children experience multiple infections, particularly upper respiratory infections, particularly in the first 3 years of life. While those infections are rarely a cause of mortality in well-developed industrialized countries, they do have a considerable impact on overall childhood health, hospitalization rates, as well as quality of life. And they pose a significant economic burden to society because of the utilization of the healthcare resources, parental work absenteeism, and secondary infections in parents and siblings. So in general, infants and young children are more predisposed to having infections, and this is relating to the relative immaturity of the immune system at birth, and this maturation occurs over the first 3 to 5 years of life. The data from the Copenhagen prospective studies on asthma in childhood followed a 2000 birth cohort, unselected population birth cohort, and reported that on average, a child would experience 14 infections during the first 3 years of life. And obviously, there was a significant variation in frequency of simple infections between otherwise healthy children. You could see that the respiratory tract infections predominate, and they're shown in the purple color, and there's significantly fewer febrile illnesses shown in orange, as well as gastrointestinal infections, which are shown in blue color. And there you can see that those infections, all kinds of the infections, but particularly respiratory tract infections, peak within the first year and a half of life, and then there's subsequent decline beyond the 3 years of life. The infections are frequently treated with antibiotics, and even though we appreciate that the majority of the upper respiratory tract infections are caused by viruses, it's unfortunately very common that, for instance, ear infections and other kind of respiratory tract infections are being managed with systemic oral antibiotics. And it's not surprising that the most frequently used drug in that study was amoxicillin, which reflects common clinical practice, followed by penicillin. Up to 30% of the infections were treated with penicillin. And you can see in the graph the breakdown of the infections that were treated with antibiotics, with even upper respiratory tract infections, colds, as well as otitis and croup treated with antibiotics. But furthermore, what is very relevant to our discussion today is that infants and young children with cow's milk allergy are more susceptible and more prone to recurrent otitis media, which is an ear infection during childhood. A recent study from Poland, which was a retrospective analysis of 280 infants with cow's milk allergy, showed that sensitization to whey protein was associated with the increased risk of recurrent respiratory tract infections in children under 2 years of age. That was almost fourfold higher in those children. And there was no difference in older ages. So this is a really interesting data that supports the clinical, impressions that we have from managing patients with allergies. The exciting data derived from 3 randomized clinical trials demonstrated that symbiotics are capable of rebalancing gut microbiota in infants with cow's milk allergy and bringing it closer to that of healthy breastfed infants. We know from prior studies that gut microbiota in children with cow's milk allergy differs from gut microbiota in healthy breastfed infants. The cow's milk allergy infants have sort of more adult type microbiota. They have decreased levels of beneficial bifidobacteria species, and they have more prevalent adult type microbiota, particularly Eubacterium rectale and Clostridia species. And when the intervention with symbiotics in infant formula was provided, there was observed a positive effect across the 3 clinical trials, which was that of increase in bifidobacteria in terms of the abundance of bifidobacteria, as well as decrease in the adult type flora, such as Eubacterium rectale and Clostridia species. So in the first trial, which was a trial of amino acid formula symbiotics in infants with IG-mediated cow's milk allergy, there was evidence that feeding with the symbiotic formula increased levels of bifidobacteria and reduced levels of Eubacterium rectale and Clostridia species. In the second trial, which enrolled infants with non-IG-mediated cow's milk allergy, we also observe similar trend that feeding amino acid based formula with symbiotics change the gut flora closer to that of healthy breastfed infants, and again with increased levels of bifidobacteria and reduced Eubacterium rectale and Clostridia species. And these effects were seen up to 26 weeks after discontinuation of therapy. And the final trial, which is the PRESTO trial, which enrolled infants with severe IG-mediated cow's milk allergy who were being fed either with amino acid-based formula with symbiotics or without symbiotics. Those who were fed formula with symbiotics had the same finding of increased in bifidobacteria abundance, as well as reduced levels of Eubacterium rectale and Clostridia. And the formula that was studied in these 3 clinical trials contain symbiotics, such a mix of short chain and long chain fructooligosaccharides, as well as Bifidobacterium breve M16V as a probiotic. This is very exciting recent data from our PRESTO study, which looked at the bacterial communities in infants who were in this clinical trial, in which we compared the amino acid-based formula with symbiotic to the standard formula, amino acid-based formula without symbiotic in infants with IG-mediated cow's milk allergy. And you can appreciate in the left graph that there is significantly more Bifidobacterium species in infants who were fed with formula with symbiotics compared to infants fed with amino acid formula without symbiotics. that in addition to the overall abundance of bifidobacteria, there was also an increased diversity of bifidobacteria species. So this is very encouraging because it confirms that indeed by feeding infants with cow's milk allergy, we are modifying their gut microbiota, and we're supporting growth of endogenous bifidobacteria, which are the beneficial, healthy gut microbiota. So let me move on to PRESTO study, and I will focus our discussion on the infections, which is the goal of my presentation. So our primary objective for that clinical trial, which was a multi-center, international, double-blind, placebo-controlled clinical trial, was to evaluate development of tolerance to cow's milk after 12 months of dietary management with amino acid-based formula with symbiotics compared to formula without symbiotics, measured by a double-blind placebo-controlled food challenge, which is the gold standard for diagnosis of food allergy, in infants with IG-mediated cow's milk allergy who are being fed with control or test product. And there are also secondary objectives, such as measurement of tolerance to cow's milk in early childhood, evaluation of the maturity of the gastrointestinal immune system in IG-mediated cow's milk allergy, to confirmation that the new formula is effective in the dietary management of cow's milk allergy, to evaluate the development of other non-food allergies such as atopic dermatitis, rhinitis, wheezing, and finally monitoring of the adverse events, so safety assessment of this formula. And in this study, we found that although there was no difference between these two study groups in terms of the frequency of overall adverse event, as well as no difference in gastrointestinal disorders, infections, and infestations, as well as specifically looking at serious adverse events, we found that there was a significantly decreased frequency of severe adverse events that were related to infection. So there are 9% of those events among the infants fed with the symbiotic formula versus the standard formula without symbiotic, which was at 20%. So this was statistically significant. And furthermore, it was in agreement with the previously reported data from randomized clinical trials with amino acid formula with symbiotics. So in the first study, which was done in slightly older children in the US with IG-mediated cow's milk allergy, it was reported that those infants who were fed with a symbiotic formula, shown in the blue bars, had significantly fewer infections and use of antibacterial, systemic antibiotics, mostly oral antibiotics, specifically amoxicillin, compared to the infants who were fed with the amino acid formula without symbiotics, which is represented as the blue bars. In the second study, which was a study of non-IG-mediated cow's milk allergy, there were significantly fewer ear infections and use of oral antibiotics reported in those infants fed with the symbiotic formula. And finally, in the PRESTO trial, we did report fewer infections requiring hospitalization. So those are serious adverse events, and all of the studies were looking at the formula that was enriched with symbiotics, a mix of fructooligosaccharides as well as Bifidobacterium breve M16V as a probiotic. The preliminary systematic review of those studies showed a positive effect or protective effect of symbiotic containing amino acid formula on frequency of ear infections. So you can see the forest plot on the left, which shows that it does the outcomes of those studies favor the new formula with symbiotic compared to the standard formula without symbiotic. And is specifically looking at the infants who received antibiotics for ear infections. You can see that significantly fewer subjects in all studies, all clinical trials, received received antibiotics compared to the infants who are being fed with a standard formula without symbiotics, which are again symbiotic formula shown in pink, and the standard amino acid based formula is shown in blue. So what is the clinical significance? As you know, as a practicing allergist, I frequently see patients in my office, and I'll discuss a case in a second. But we do know that infants in general, even healthy infants without atopic predisposition, are born with an immature immune system, which is characterized by particular immaturity of the Th1 anti-infective responses, while having predominance of Th2 responses that is present at birth. And over the first few years of life, there's a gradual maturation of the Th1 anti-infective immunity, usually over the first 3 to 5 years of life. This maturation and the Th skewing is much, the maturation is delayed, and the Th skewing is more pronounced in the infants of atopic background, so with risk factors. In addition, there is evidence that gut dysbiosis may be present in infants who are predisposed to develop food allergy in particular, as well as those who are being formula fed have also, as we've shown, have a different composition of the gut microbiota. So all of these factors translate into predisposition to develop atopy, but at the same time, those atopic infants are at increased risk for infections in the first 3 years of life. So just to remind you, the just healthy population-based birth cohort reported median 14 infections during the first 3 years of life, and there was significantly higher use of antibiotics in ear infections and respiratory tract infections, with the most frequently used antibiotic being amoxicillin, that was followed by penicillin, up to 30% of the infants and children. So I just want to share with you my reflection on a sort of a typical infant patient in the pediatric allergy clinic. So let's call him Bobby. As a male infant who was born at term without any pregnancy or perinatal complications. He was being fed with cow's milk formula since birth because of the poor breast milk supply in his mom. At 6 weeks, Bobby was found to have an itchy and oozy rash and was given a diagnosis of atopic dermatitis. And because he wasn't gaining weight and his rash became more severe, he was diagnosed with cow's milk allergy at 4 months of age, and he was switched to a hypoallergenic, extensively hydrolyzed formula without significant improvement in his symptoms. So ultimately, he was transitioned to amino acid formula due to ongoing symptoms and poor weight gain. With the amino acid formula, he did improve his symptoms, cutaneous rashes, as well as achieve normal weight gain. So between the age of 6 to 12 months, Bobby had 3 episodes of otitis media that were treated with amoxicillin. And finally, at 13 months of age, he was given ear tubes, or pressure equalizing tubes, which helped subsequent infections. And at 15 months of age, he had a first episode of wheezing. At that time, he was referred to the allergy clinic for evaluation. And his parents were reading, in the press about the importance of healthy microbiota. So they asked whether it would be appropriate to start probiotic supplementation. And I wonder if we, were able to supplement Bobby with the formula that contains symbiotics at birth when he wasn't breastfed, whether we would be able to alter his natural history and protect him from frequent infection, frequent antibiotic use, which might have contributed to his development of those additional allergic problems. So in summary, new generation of hypoallergenic infant formula symbiotic replicates the immunomodulatory effects of breast milk. Breast milk is a immunologically active fluid which contains bacteria. It is not sterile. It contains healthy, beneficial bacteria. It contains also human milk oligosaccharides and lactose, which are act as prebiotics, and also contains IgA. Amino acid formula with symbiotics has been shown consistently shown in 3 clinical trials to promote colonization of the infant gut with beneficial bacterial communities, particularly bifidobacteria, which bring it closer to the profile of the gut microbiota that is seen in infants who are healthy infants who are breastfed. And furthermore, in addition to modulating the gut microbiota, the amino acid formula with symbiotic had a consistent protective effect from infections in early life, and this effect has been consistently reported from 3 clinical trials. And I would say that this is a really of special clinical relevance for infants who are atopic, who are born with predisposition to develop frequent infections due to the immaturity of the Th1 responses and skewing towards the Th2 responses. So with that, I want to thank my co-investigators on the Presto trial, as well as the Nano Nutricia research for supporting this important clinical investigation. Thank you very much.
So thank you very much, Anna, for that concise presentation. And now it's time for our discussion. So we've heard quite a lot of interesting information. We all know that allergy management is changing. It has changed lately to move to a more proactive approach in regards to allergen particularly, but also in regards to the environment in which the allergens are presented. So we heard in the talks about the major importance of microbiota composition in relation to overall health, particularly immune health and protection from dysbiosis and allergy. And we understood the different immunoactive components and how we need to approach them for developing products closer to the ideal, of course, breast milk, which is the ideal. And then Kirsten described to us the Presto study, which compared an amino acid formula without or with symbiotics on the outgrowth of cow's milk allergy after a year, where we saw that about half of the infants outgrew their allergy, but with no further improvement with the symbiotic. However, the latter group had suffered less infections, and that was the focus of the topic of the last presentation of Anna, who showed us that symbiotics can rebalance the dysbiotic microbiome in children with allergies and emphasize its messages about infections, not only in Presto, but also in other studies using the same symbiotic mixture. So a bonus from that was also reduced in antibiotic use. So we have very interesting things to discuss, starting from the symbiotics to understand a little bit about the symbiotics. And I would like to ask Jan, how do symbiotics compare to HMOs? And what is the evidence in allergic infants for each of these?
Those are interesting concepts indeed that you see appearing in infant nutrition research and also sometimes in products. And I think it's all based on microbiome modulation. So there is a commonality maybe. Important, of course, to steer the composition of the microbiome by stimulating beneficial bacteria over maybe some others. But also the activity of the bacteria, because that's, of course, also important, that they produce the short-chain fatty acids, create an environment that is beneficial for other beneficial microbes, really, let's say, improving the quality of the ecosystem, very much what we see, of course, in healthy breastfed infants as well. I think the evidence on HMO is still very scarce. It's a new field. These HMOs have not been available for a long time because we were not able to produce them in sufficient amounts, but these days that's possible, at least some of them. And of course, these are substrates for microbes, but the symbiotics, I think, is a different concept in the sense that it also contains live bacteria, plus also the substrates that these bacteria need. And I think this is interesting because in this way we can really bring live microorganisms into the ecosystem, feed them, and then directly make sure that the short-chain fatty acids are produced, that the bifidobacteria are active and can influence the ecosystem. And that, I think, we have shown in now many different studies that through this concept, you can clearly support the developing microbiome in early life, bringing it closer to breastfed infants.
So are the prebiotics and the HMOs inherently good? Or it is possible that in some situations, these might also feed some not so good bacteria?
Yeah, that's something we have to be aware of. I think some, for example, E. coli, they are also, you have good types of E. coli, but also bad types, as we know. And these, for example, can also use many different sugar structures. So how this then works out in the ecosystem needs to be studied. And I think this is maybe not always there. And of course, in human milk, it's really a mix of many different structures of human milk oligosaccharides. Whereas in current studies, there's mostly performed, of course, with one single molecule isolated from the complex mix and studied for their effects. And yeah, I think we still then need to indeed also look at effects on other types of microbes that might be able to use these sugar molecules.
So do you think that the present is good enough? And how will the future be? So will prebiotic and one probiotic together, so one symbiotic will do the job, or do we really need to go much further to understand the complexity and take advantage of the complexity?
Well, I think we do. In general, some concepts I think are important. I think human milk is clearly rich in fiber, so substrates for microorganisms, the human milk oligosaccharides. Many infant formulas are not, if they don't have these prebiotics, because cow's milk doesn't have this fiber level, or plant-based products, they don't have these high levels of complex sugars that can serve as fibers. But that's a general concept, I think. We need to feed the microbes with energy and carbon that they can grow, produce short chain fatty acids. But to really steer it also very specifically towards a specific composition and activity, yes, we need to indeed look at more specific mixtures, I think. And I think what is going to be important is also to look at the issue or the infant. So it may be that certain infants need different things than other infants, like C-section versus vaginal, or infants that need antibiotics, or infants that are already allergic. If we really know the microbial profiles, we can probably also design much more sophisticated or designed biotics to really steer the microbiome in a better direction.
I think that we'll come back to these ideas in a little while, but I thought that it's time to ask more about the study and go into Kirsty about outgrowth of cow's milk allergy in the PRESTO trial. And there was no difference between the symbiotic or without the symbiotic. Why do you think this happened? How can you explain it?
It's a very interesting question. First of all, I can say that we were very happy to see that the children have a fantastic tolerance development, similar as we have seen in other studies. And you were also involved in the Europroval birth cohort study, and the tolerance development we observed over there in a birth cohort really was reflected in the PRESTO trial. And another issue is that these children were fed an amino acid formula. And we heard often in the past that people said, oh, an amino acid formula might not induce tolerance and that will be a problem. At least it was possible to show that an amino acid formula gives a similar tolerance development as with other, like an extensive hydrolyzed formula, for example. So first of all, we were very happy to see this. Of course, we were a little unhappy to see that there was no difference whether you use symbiotics or not. However, looking at other parameters, and I will not go into infection, I think this is what Anja will talk later about, but we will also follow these children up in regard to development of other food allergies, and also a 6-year follow-up will occur, and there we will look at other atopic diseases. And I'm still curious whether we will see any effect in this regard. So yes, I'm disappointed a little bit. I have no explanation why this occurred, but maybe this is not something what is really necessary for tolerance development, because it's already fantastic, the tolerance development. But we will see in regard to other parameters we look at.
So do you think that this was results of quantitative difference? Do you think that there was the maximum level of tolerance that could have been achieved and the children achieved it anyway? Or do you think that it might be qualitative, it might be related to antigen? So you think if there was milk allergen in there, that could have changed the result?
I think in general, we know that children with cow's milk allergy are exposed to little amounts of cow's milk constantly, as long as they get any additional feeding instead of formula or mother's milk, because we know that cow's milk contamination in bakery products and a lot of things often occur. So, so getting some cow's milk that might lead to a tolerance development occur all the time in many of the patients. Whether this is already the maximum what we see in tolerance development, I would say no. Still about 30% of the children are still allergic, and we hope that they will gain tolerance. Again, at 6 years, we might see that some of the children gain faster tolerance than others, the one with the symbiotics maybe, but we don't know. Maybe there will be a difference, maybe not. And I'm very curious to see this data then. But 70% is not enough. We need 100% tolerance development.
Do we have information about the microbiota composition at that age, and whether the lack of tolerance is associated also with a lack of eubiosis? And that's both for Kirsten and for Jan.
So I let Jan first answer. He's an expert.
No, I don't know. I don't think there's a lot of detailed information, but this could be important. And I think it's also maybe important to study a bit better the window where these things happen. Do we, in the right time, have the right condition in the gut, which is maybe slightly inflammatory or not in a developing gut, when we introduce antigens, allergens? I don't think we really know where this programming, or how you would call it, where it takes place. But if we know also this better, I think that's where we then should also probably study the microbiome and what it does, and not so much when symptoms appear. So I think we still have some work to do.
Anya, if you had to choose about intervention with an antigen and intervention with a microbial product, what would you choose?
That's a tough question, Nikos. You know, I think I will go back to Jan and say depends when and depends who, right? You know, I think if we are thinking, I mean, there's enough data to say that infants who will develop allergy, food allergy or asthma, they have a different microbiota at birth. So, you know, if I were taking somebody who is at risk and I was trying to, you know, change the trajectory, then I would say I would like to change the microbiota, because it's, you know, there's good evidence to say that this microbiota may determine sort of the natural course of the disease. I think if somebody is already allergic, then, you know, we will have to really weigh the risks and benefits. You know, introducing allergen or antigen comes at a price. You know, it's a much more involved process, and it's not available for everybody. So I think in the future we will move towards more personalized, you know, treatments, and we'll, you know, be able to say what is the best intervention for this particular patient. And you know, also I would like to go back to the data I presented, where the effect of the symbiotic was obvious both for IgE as well as non-IgE mediated cow's milk allergy. And we know that for the non-IgE, well, we don't have evidence that for non-IgE mediated allergy, introduction of allergen is a viable option. So I think that going forward, when we accumulate more evidence, we'll have more clarity to say who, you know, when, and what intervention we should introduce.
Yeah, so for the time being, we know that antigen works, but we would bet more on the microbial environment, which is much more difficult as a bet though. And I would also agree and think that personalized interventions would be great, but how feasible and how close are we to these interventions? We have just started to understand how the structures of microbiomes, of gut microbiomes. And do you think that, Dr. Jan, do you think that we can shift them somehow? Are there any, so specifically shift them, not generally, but try to have an effect on a specified microbiome element, for example?
Yeah. No, and what is a healthy microbiome and what is optimal? It may also be linked to the genes of the infant. So it's quite a difficult question, I think. But of course, a healthy breastfed infant is still a reference. So I think we can still learn from that, and some basic principles we can still try to mimic, like the pH, the short-chain fatty acids at a certain time, but also, let's say, LPS, certain types of bacteria. But if it's very specific, if very specific microbial antigens can trigger T cells or influence immune maturation, yeah, then it's going to be, of course, more important to know these mechanisms and to see if these are general or very specific in individuals. And of course, our tools are kind of limited to do or to bring in microbes to the system that are not considered safe as a food ingredient. Of course, there's hundreds of species in the gut that would maybe be lacking in allergic infants, but we cannot add them to the diet because we don't know the safety and yeah, if it's even feasible to get them alive in a product. So we also need to understand the ecosystem. So what conditions does the ecosystem need to support the growth of these species in the gut? And that's quite a challenge, but it can be many things more than just sugars. It could also be nitrogen sources or vitamins or other parts of the diet that can certainly help us, I think, to steer the composition and activity of the microbiome in a certain direction.
So Kirsten, to go back to the present trial, were there any different effects in regard to location, for example, differences between countries or differences between continents? And the reason that I'm thinking about it or asking is that perhaps weaning practices or exposure to other foods that might contain also microbes might affect the outcome. Any thoughts or any possibilities that this can be something that we need to look more into?
Yes, of course. We looked into this, and at the moment, from the data, as far we have analyzed this data, there seemed to be no influence from the different countries. Of course, it's an interesting thought, but at the moment, we have no data to support it. However, the study was also not powered to find these differences.
So we still have quite a lot to learn. However, I think the observation that there were less infections in the present trial, but also in other trials with a symbiotic is a really important one. So Anja, can you comment a little bit about the differences in infections, different types of infections in breastfed infants and in formula-fed infants, and then starting from there, see how we can see and how we can explain the difference observed with the symbiotic?
Yeah, as we mentioned before, breast milk is the gold standard of infant nutrition, and breastfed infants have generally fewer infections, upper respiratory infections, gastrointestinal infections. So and there's also evidence that infants with cow's milk allergy are more prone to infections, particularly upper respiratory infections, lower respiratory infections, as well as otitis media. This is probably the biggest problem. Most of the time this is a viral infection, but it leads to prescription of oral antibiotics, mostly amoxicillin, and this has been seen, sort of across the board in different countries. So, unnecessary use of antibiotics is even higher in infants with food allergy, particularly cow's milk allergy, than in healthy infants. And this contributes to the disturbed microbiota. So I think that this was a very exciting observation, and the study wasn't powered. This was a secondary outcome. It was a safety outcome that was evaluated in terms of the infection. And in Presto's study, we've seen a significant difference in terms of the severe infections that were leading to hospitalizations, which were decreased in symbiotic group compared to the standard formula. In the two other trials, there were observed significant differences in otitis media, in upper respiratory infections, as well as the use of antibiotics. And those two other trials, one trial was done in the US in IgE-mediated cow's milk allergy, another was a European trial with included infants with non-IgE, so gastrointestinal food allergy, but they produce very similar outcomes. So I mean, altogether, those trials included more than 300 infants, and we've seen the same signal, which I think is very, very interesting. And even though, considering that these studies were not powered or designed really to evaluate, so those are sort of incidental observation, but it seems that it could be very important going forward in our, understanding of how we should feed those infants who are at risk or who already have developed the cow's milk allergy or other food allergies.
And because I mean, these observations point us towards the possibility that there is a general immune stimulation, and actually protection can be related to infections which are most probably not bacterial but rather viral, which the otitis media will be. And that's one thing that I would come to my mind. And the second thing is that if this happens in allergic infants and then they get more antibiotics, then they will generate more dysbiosis, and this will make them even more susceptible. And then in the future, we will actually see differences that will be iatrogenic, basically. That will be because we are interfering with their gut microbiome. However, do you think that, I mean, of course, I would like you to comment on these thoughts, but also think whether we can power studies based on these observations, how large they should be and how long. That's really important.
Well, in terms of the power, we were able to detect, those differences in relatively small studies, but I would have to defer to the statisticians. It's probably several hundreds or more, and duration. I would think you would like to observe participants for at least a year, to really get a sense of a trend, or, ideally first 3 years of life where those infections are the most common. There's another thing that I wanted to point out, in addition to antibiotics, we know that infections in infancy are frequently associated with fevers and use of antipyretics. And also that was another observation, that there was decreased use of antipyretics in those infants that were treated, fed with formula with symbiotics in the other trials, not particularly in PRESTO trials. So I think, there's a lot of observations, there have been linking acetaminophen, so Tylenol, to asthma, for instance, later in life. So it will be very interesting to have those, future studies and observations. And I think that what's so super exciting and valuable about the PRESTO trial, as Kirsten pointed out, is the long-term follow-up. We will be watching those children for the next 6 years and hopefully maybe even longer, and just really see if we have made a long-lasting difference.
Great. And I think we need to, go to what is the final conclusion from all these thoughts and these studies. And I would ask Kirsten, what do you think about the recommendations? How are your views about managing cow's milk allergy? Have they changed with the results of PRESTO? And what do you think the recommendation should be at this point?
So at the moment, I would say from the result of PRESTO, the treatment of cow's milk allergy has not changed. So we have still the elimination diet, what is most important in cow's milk allergy. And as cow's milk is a very important nutrition, so most of the children need something when they can't have cow's milk. So it could be an extensively hydrolyzed formula or an amino acid formula. We have now shown clearly that also with amino acid formula, the tolerance development is similar as in other studies, and seems to be, at least when we compare to some other data, even better than for extensively hydrolyzed formula. So at the moment, no change, still elimination, and something for the children what can be given to them. Okay. But let's wait for the 6-year follow-up.
Yeah, well, we still have to do something in the next few years, in the next 5 years. So what about in your clinic, Anya? Would you advise parents to use symbiotics, or in which situation, what time, what condition that you would advise to think about symbiotics?
So, I do, of course, agree with Kirsten, and you know very well, Nikos, that to issue a guideline changing the clinical practice, you really need super strong evidence, and this evidence has to be rigorously evaluated. And I think we're going to get to that point, you know, when we accumulate more information, more evidence supporting the use of symbiotics. If obviously I do support, as all of us support, breastfeeding. So for infants with cow's milk allergy or infants with, you know, any other food allergies as much as possible, because we still haven't reached this gold standard, right? Like we're trying to emulate the breast milk, but even new generation of hypoallergenic formulas are not, you know, equivalent to breast milk by no means. So first of all, would be to encourage breastfeeding, to encourage the healthy diet in the mother, you know, try to limit unnecessary restrictions in the maternal diet. And then if I have to switch, you know, if the formula is indicated, I would consider formula with symbiotic, because I think, you know, we have shown that it's for healthy, otherwise healthy infants who don't have, you know, suspected immunodeficiency, you know, those formulas are safe and they're well tolerated. So I think that they're not going to hurt, they can only help, you know, and in terms of the growth and safety, they're equivalent to formulas without symbiotics. So, you know, there may be other issues that will come into this decision process, you know, depending on the country. There may be a price issue, you know, for the country where I practice, US is it's not a big difference, you know. The other issue, is it covered by the, you know, health insurance, by the health system, etc. But I think in general, I think this makes a lot of sense. In particular, I would think that this would be indicated in situations where we suspect that the microbiota can be further sort of disturbed, such as, you know, birth by cesarean section, or mother receiving antibiotics during pregnancy, or, you know, during lactation. Then I would think like, I would think that this would be a good intervention. But that's my, you know, that's my opinion. It's not a guideline, right?
Definitely, we're not issuing guidelines. Well, there is a question that comes up all the time, and you've touched it, and it's about safety. So I will go to Jan as a microbiologist. Are the symbiotics, are they safe? Are they completely safe?
Well, you say symbiotics, but I think we talk about a very specific symbiotic here with a very specific strain of Brava, the M16V, and a GOS-FOS or FOS-FOS mixture. I think if you talk about this specific symbiotic, I think there's a lot of evidence showing indeed that it's safe. It's been tested in growth and safety studies in healthy infants, in allergic infants, in preterms, and this has always been used without any safety concern. So I think in that sense, it's a very well studied symbiotic that I think we can really prove that it's safe, even in allergic infants, which may be a little bit immune compromised, but it seemed to be completely safe.
Great. Well, I think that we had a great discussion. I would like to thank you all. I would like to thank also Nutricia for organizing this and recording this session. And it's obvious that we have a long way to go, but we are finding every time more and more interesting results, and we are helping children with cow's milk allergy and other allergic diseases. Thank you very much.
Thanks, Nikos.
Thank you.
Thank you.
Bye.